Good afternoon, and thank you for taking the time to join us today for this webinar on the important topic of the safe administration of oxytocin, hosted by the Provincial Council for Maternal and Child Health, otherwise known as PCMCH. My name is Brittany Groom. I'm a program manager at PCMCH, and I will be setting the stage before handing it over to our brilliant panel of speakers. If you could take a moment to introduce yourself in the chat. We want to get a sense today of who is joining us. If you feel comfortable sharing your name, your role, your title, and your organization, so we get a sense of who is in our audience. Next slide. Before we begin, it's really important to acknowledge the land on which PCMCH operates. This land is the territory of the Haudenosaunee, Wendat, and Anishinaabe people, and is governed by the Dish with One Spoon Treaty. This nation-to-nation agreement committed these nations to share the territory in peace, friendship, and respect. All newcomers are symbolically included in this treaty and in the spirit of these obligations. Today, Toronto is home to Indigenous peoples from across Turtle Island. We recognize that PCMCH's members and stakeholders are located on traditional Indigenous territories across Ontario. So I encourage every participant here to reflect on the land you are on, who the traditional keepers of the land are, and what the treaty relationship is, or if it is unceded territory. For those of you that may not be familiar with the Zoom webinar platform we are using today, you can utilize the Q&A tab to ask questions throughout the webinar, and we will do our best to answer everything, and we'll also issue a follow-up written printable Q&A summary if there's a ton of unanswered questions. So please feel free to put those in the Q&A as you go, and we'll try and answer some of them live or by written chat, and we'll do our best to respond to those after as well. Please do note that this webinar is being recorded, and the recording will be available afterwards on our PCMCH site. So if you have to step off earlier or you'd like to share this with colleagues, the option will be there, and within the week should be posted. As you are all keenly aware, IV oxytocin is a high alert medication and one that can cause significant patient harm when used inappropriately. PCMCH aims to lead practice change on the frontline level by developing a set of best practices and driving their implementation across the province to ensure a standardizing approach. In 2019, PCMCH released a Safe Administration of Oxytocin report outlining 11 best practice recommendations for the safe management of pregnant patients whose labor is induced or augmented with the medication oxytocin. At that time, 96 birthing hospitals in Ontario were contacted to provide their order sets and protocols for oxytocin administration, and significant variation was noted, especially with respect to the concentration of prepared oxytocin infusions. Protocols across Canada and internationally were also looked at the time, and it was highlighted that the inappropriate use of oxytocin and poor fetal health surveillance interpretation needed to be addressed in a standardized way in order to reduce poor birth outcomes. So on your right of the screen, you'll see to support implementation of these best practice recommendations, various tools and resources were developed by PCMCH and other organizations. In addition, a new implementation toolkit was developed and released in January of this year. You'll hear more about that later on in this webinar. But our last thing I want to say is if you have a mobile device on hand or are working on your computer, I encourage you to scan the QR code or visit our oxytocin webpage to reference the various documents as we flow through this session. So we have an action-packed hour together, so let's get into it by introducing our first speaker. Joanna Noble is the lead special operations within the Healthcare Safety and Risk Management Division at Healthcare Insurance Reciprocal of Canada. She has over 20 years experience in patient safety, risk, quality, nursing, and insurance, and contributes regularly to external forums, publications, and committees on diverse risk and safety issues. Joanna leads the knowledge translation of medical legal claims and evidence-based practice into patient safety knowledge with a focus on obstetrics, perinatal, and midwifery.
Thank you so much for this opportunity to speak to you today. If you could advance the next slide, that'd be great. Thank you. So I'm going to start off talking a little bit about HIROC. I'll help to explain our lens on the world. So we're the Healthcare Insurance Reciprocal of Canada. We're a not-for-profit organization that's owned and governed by those that we insure. And part of what we do is that we invest in quality, risk, and patient safety, and partner with organizations such as PCMCH and others to really encourage evidence-based informed risk management taking in Canada. Next slide, please. So this kind of sets the stage in terms of who we insure. So we insure over 700 healthcare organizations across Canada, and we insure over 1,000 registered midwives, including midwives who work under legislative exemption. So we do partner, as I mentioned earlier, in terms of making sure that the perinatal environment is as safe as possible. Next slide, please. So in terms of who specifically is covered off in our claims, or who do we provide medical malpractice insurance to, so you can see HIROC on the left-hand side, and then you see midwives. So we have a pool of midwives that we do insure across Canada, over 1,000, and then we also insure healthcare organizations and systems, such as large health regions, to small long-term care, to large community health centers, etc. So we do extend legal assistance to those that work for the organizations, such as employees and volunteers, as well as students, as long as they work under the guise of the organization. We also extend coverage to boards and affiliated like organizations, and we do extend coverage to physicians, dentists, interns, etc., as long as they're working within their administrative capacity. Next slide, please. So it's probably no surprise to anyone, but maternal neonatal claims are HIROC'S most expensive type of claim. We call them low frequency in terms of how often they occur, but they have a high severity characteristic. So what we're seeing in a lot of these cases is that there's a high degree of preventability. And we know that it's not just one factor that actually contributes to the outcome. And we know that when these events do occur, they are infrequent, but when they do occur, they have a significant impact on families, clinicians, and healthcare organizations. So in terms of just how frequent or infrequent these cases are, it's fair to suggest that 1 in 1,000 insured HIROC births are reported to us as a potential matter or an actual matter. Now, these matters, when they do arise, it takes a long time to resolve. Generally, the legal action is commenced within 2 to 6 years, and that's around the age when that child starts to interact with their peers, so we get a better sense in terms of their future outcome. When I first started at HIROC, I assumed that if you were not sued within the first 1 or 2 years, you couldn't be sued, but you can. Often, many of these cases involves a child that has long-term neurological sequela, so really there is no limitation period. Now, if you were to Google HIROC and medical malpractice and obstetrics, you probably wouldn't see a lot of cases. And that's in part due to the fact that we don't go to trial too often. We know going to trial is very complex, very expensive, and it has a significant impact on everyone. So where we need to pursue it, or where it is pursued, we often will look at other alternatives such as mediation or out-of-court settlement. So what we do know about these cases is that often the documentation to support some of the clinical decision-making just isn't there. So we often say that documentation can really make or break such a case. Next slide, please. So IV oxytocin, or the mismanagement of induction augmentation medication, is HIROC'S second highest ranked claim type. And so what we do every couple of years, we go into our claims database, we do an extract, and then we do a sort and an evaluation, and then come up with what we call our top 30 ranked risks. So you can see that IV oxytocin is number 2 for the year 2020. So what we've done with each one of our top ranked risks is create a risk reference sheet. So that's publicly available on our website, should it be of interest. Next slide, please. So what I did is I extracted some of the common contributing factors, and I think you'll hear throughout this session that these are quite common, and there really is a need to focus in on some of these contributing factors. So what we know in some jurisdictions and in some sites, it's overused, or misused. It may be used for the wrong purposes. We know that you can have the best possible clinicians, but if the team is not functioning well, it really negatively impacts the safety of the induction or the augmentation. We are aware, as you heard earlier, about some discrepant practices and inconsistencies in terms of dosing regimes as it relates to the management of induction and augmentation. Next slide, please. We do see, unfortunately, in quite a few cases, there is an order, a questionable order, but the practitioners actually initiate it. Maybe they feel that they should just follow it because as per protocol, or perhaps because the physician said so. But I think what we know is that those that are actually, starting or inducing the labor have a professional accountability to make sure that they're satisfied with that order. We see a lot of cases where the whole team basically missed the boat. So when you look back at the tracings or the fetal health surveillance, there is evidence just that both the maternal and or fetus was not doing well, and they should not even started it, or perhaps they should have stopped it. We see a lot of cases where, unfortunately, the staff are not aware or don't comply. And most recently, we've seen a real focus on the informed consent. It's fair to suggest that this is a fairly new change in terms of what we're seeing in our cases, but I think it's here to stay. And then we see, as you'll hear in some of the case studies, poor team communication, including lack of formal escalation and chain of command protocols that really encourage and welcome that feedback as it relates to IV oxytocin. Next slide, please. So I think what you'll hear throughout these cases is what's called the softer skills. These are often more difficult than some of the technical skills. So you can see on the left-hand side is it takes a whole team to really ensure the safety as it relates to aviation, but the same with the use of IV oxytocin. And on the right-hand side, you see that concept of situational awareness. Often we get so caught up in the details that we really do miss the big picture. Next slide, please. So in terms of, this really does matter to HIROC. And so over the last couple of years, in alignment with our strategic planning, we really identified what we call our top safety themes that we want to focus our efforts on. So you can see on the left-hand side, the criteria that we use to identify these safety indicators. And then you can see the objective. And then you see the primary and secondary drivers. So these really do drive our day-to-day operations and also in terms of our support for the greater healthcare community. And you can see IV oxytocin did make our list. Next slide, please. So some of you may be familiar with this report that we did with the Canadian Medical Protective Association back in 2018. So it was a follow-up report to one that we did with Salus Global and Accreditation Canada, looking at the top themes related to obstetrics. So we did a deep dive into our respective databases to identify and really explore some of the contributing factors. So the management of induction and augmentation medications was one of our top areas of focus. Next slide, please. So some of these findings may be a bit alarming to some, but maybe not for others. So we broke it down into, again, contributing factors. So you can see at the top, it's lack of awareness and compliance with oxytocin-related protocols. So HIROC that's 49%. So that's a frequency, how often it occurs in our cases. And then in the brackets, you see the percentage for CMPA. I think the one that really stands out actually the two that really stand out for me is number 2, the delayed in notification where indicated, and at the very bottom, not discontinuing the rate of infusion where indicated. Next slide, please. So that's, from a perspective looking at our claims database, but really what are your peers suggesting? So we have a tool called Risk Register. It follows the concepts of integrated risk management. So it allows an organization to identify their top ranked risks based on what they're experiencing. And it was a bit of a surprise to us, but the idea of birth trauma. So this really encompasses both harm to mom and baby. It was the top ranked risk by your peers by impact. And again, that was really surprising to us. So something probably has happened over the last couple of years to really escalate the concept of perinatal safety. And then on the right-hand side, you can see once again birth trauma, and you can see it's the third highest ranked risk by overall rating. Next slide, please. Thank you very much. So I'll hand this over.
Joanna, thank you for providing that really important background and context from a safety and risk perspective. Next up to speak, we have Dr. Mark Walker, obstetrician and gynecologist and clinical specialist in maternal fetal medicine at the Ottawa Hospital. Mark is also the interim vice dean of internationalization and global health at the University of Ottawa, and scientific director with Born Ontario and medical lead of obstetrics and gynecology with the Champlain Maternal Newborn Regional Program. Mark has expertly co-led this initiative over the past few years working with PCMCH.
Great. Thanks very much, Brittany, and welcome everyone. I'm just going to go off script a little bit and just give a big kudos to the team that's made this happen. This has been many years in the planning, as Joanna will know. Same with working with CMPA. We'd had proposals. The slides were changing 4 or 5 years ago, and a whole package of safer obstetrics, and the one that we didn't get the funding that we're hoping, the one that we've done, we thought it had the highest rate of returns on the safety of oxytocin, and particularly the 3 things around the use of oxytocin. One was standardization, which just addresses, documentation, which just addresses, and communication. So I just want to give a big shout out to the team at PCMCH who have been unbelievable in putting this together, starting with Laura Zahardine, who's on maternity leave. I don't know if you're on, Laura, I didn't see you, but really, got this going, and then Tracy and Brittany have taken it to the next stage and really bring it over the finish line. So congratulations. I want to thank Gareth as well as the co-lead has been fantastic, as well as Rob Grattan, who was instrumental in making this happen. So this, is really a big transformation, I think, for practice and standardization in Ontario, and really proud of all the work. The goal of this work is to standardize oxytocin administration practice to promote safe induction and augmentation of labor. The objective of the report, this 11 recommendation, is to reduce the risk of misuse and or mismanagement of oxytocin by addressing risk factors that have contributed to common errors in its administration. To promote a culture of safety when using high alert medications, 11 best practice recommendations were identified and vetted by clinical experts and endorsed by a number of organizations, including the CMPA and HIROC and SOGC. Without going into great detail about the recommendations, participants can see in the table on the left-hand side topics of communication, medication handling, hospital preparedness, and more are covered. And as I mentioned, this has been endorsed by all the national organizations. Next slide, please. So to complement the 11 best practice recommendations, a number of tools were developed by PCMCH and in collaboration with other organizations. For example, an education pamphlet was created in partnership with Best Start Health Nexus and tested and validated by patients. Another example, standardized medication labels were developed in consultation with the Institute for Safe Medication Practices Canada. ISMP also developed a patient handout titled 5 Questions to Ask, Oxytocin to Store or Advance Labor. The handout provides information about the benefits and risks of IV oxytocin and can be used to support healthcare provider and patient conversations. And lastly, certain tools can be tailored to your organization. If you get in touch with PCMCH, so Brittany or Tracy, for an editable version, for example, the order set can be edited and possibly embedded within your EMR to support implementation. Next slide, please. This is a closer look at one of the tools developed, a decision tree to guide situations where there is a disagreement with a plan of care. The algorithm ties in a few of the best practice recommendations, including interprofessional team communication, indications for induction or augmentation, and professional skills training. You can utilize this to support interprofessional team training and skills drills to empower individuals to communicate effectively and escalate safety concerns during oxytocin administration. Keep this in mind for when we get close to case studies later in this webinar. There's also a decision tree tool for making decisions to start IV oxytocin. Next slide, please. There are 2 safety checklists, very similar to the surgical safety checklist. One pre-use that provides an opportunity for healthcare providers to pause and reflect on a patient's eligibility and safety considerations prior to administering oxytocin. On your screen, you can see a snapshot of the in-use oxytocin safety checklist is written on all of the documents. Please note that the focus in low-risk patients with a singleton cephalic term pregnancy. However, the recommendations and tools may still be applicable to patients outside of this low-risk definition. Next slide. This is the implementation toolkit. I have to say, I love this. It's intended to support hospitals in identifying which best practice recommendations to prioritize and implement. The toolkit aims to provide implementation by providing tools and tips that can be applied in practice to bridge, identify gaps, and ultimately enhance safety in administering oxytocin. And the beauty of the toolkit is it works with all institutions because it does a gap analysis. Some will be complete in some centers and others not in others. We know that successful implementation, adoption, and sustained use requires that the 11 recommendations can be tailored at the local level to your unit and organizational needs. This is an example of the gap analysis template. A new gap analysis template was developed and included in the implementation toolkit. This template should be used to determine the hospital's current state in relation to safe administration of oxytocin recommendations and to identify potential areas for improvement. This template can guide team discussions amongst clinical and administrative staff to identify why current gaps exist, what desired outcomes are wanted, and to determine the actionable steps to be taken to address those gaps. An implementation team can be developed with a wide range of diverse perspectives and executive leadership support to ensure effective change management and sustained change in practices. Back over to you, team.
Thanks, Mark. Appreciate that. Now we can jump into some case studies and really put the recommendations and what we've heard so far into action. We do recognize, I'll preface it by saying that real life clinical situations are far more complex and there's a lot more factors to consider. So with these case reviews, this does not negate clinical judgment and decision making, but rather we're just trying to give examples to guide and support the recommendations and tools and to mitigate some risk. And I will say that these case studies were adapted from HIROC case studies. So I'd like to introduce now Dr. Gareth Seaward. He is a professor in the Department of Obstetrics and Gynecology and the Institute of Health Policy Management and Evaluation at the University of Toronto. He served in various leadership roles at PCMCH for 12 years, implementing many improvements in maternal infant care in Ontario. This also included co-chairing PCMCH's Maternal Newborn Committee and being the Quality Improvement Advisor for this Oxytocin initiative since its inception. He is a maternal fetal medicine specialist, Deputy Director of the Fetal Medicine Unit at Mount Sinai Hospital, and a member of the Ontario Fetal Centre. And we are also so pleased to have Lauren Rivard, a perinatal consultant with the Champlain Maternal Newborn Regional Program with us. She is also extensively involved in fetal health surveillance and neonatal resuscitation, facilitating education for both learners and instructors. She is currently a co-chair of the Canadian Fetal Health Surveillance Steering Committee and the Canadian Fetal Health Surveillance Executive, as well as a member of the Canadian Pediatric Society's Neonatal Resuscitation Program Steering and Executive. She is an active member on multiple regional, provincial, and national committees, including the SRGC's Intrapartum Fetal Health Surveillance Clinical Consensus Guideline and Accreditation Canada's Perinatal Technical Committee. I'll now pass it over to you, Gareth, to get started on case study number 1.
Thank you. Hi, everyone. So the case studies that we're going to present are a tool to help introduce you to some of the tools we actually have within our guidelines for the use of oxytocin that would help people negotiate or navigate problems that are encountered when using oxytocin. It's not really meant to be a discussion on what dose of oxytocin to use and overall interpretation of tracings. It's more to help you realize that there are tools within this package that we have developed that should help people as I said, navigate those tricky cases. So the first case was basically somebody who was scheduled for a post-dates induction as an outpatient who went into active labor on her own and then was admitted to hospital where continuous electronic fetal monitoring was applied. It was noted at the time of admission that there was light meconium staining of the amniotic fluid. And interestingly enough, this is where people should pay attention to use of tools. During the first stage of labor, there were a number of episodes of fetal tachycardia and decelerations when one looked back at the overall notation in the chart. However, despite this, intravenous oxytocin was commenced and increased, and I will show you the tracing in a moment. Ultimately, the woman was delivered by an assisted vaginal delivery using Simpson forceps. Unfortunately, the baby had APGAR scores of 1, 4 at 4, and 1 at 5 and 10 minutes respectively. And this infant ultimately sustained severe hypoxic ischemic encephalopathy despite aggressive management in the immediate newborn period, including cooling therapy. So the issue really is, if one looks back at this and looks at the fetal tracing and so on, is what actually went on in people's minds. Can I have the next slide, please, Tracy? So this is just a snapshot of this fetal tracing. Remember, there were periods when the fetal tracing could not be adequately obtained, but this is what it looked like when it was obtained by the bedside healthcare provider. And just, to remind you of the issues of what constitutes uncomplicated variables versus variables that are complicated, I put this small box in the end. But one can actually see there are significant issues with the type of variable deceleration that is occurring, with a baseline that is trending up towards a tachycardia. And the problem with all of this is that despite these warning signs on the fetal tracing, oxytocin was increased. Not only did they continue with the oxytocin, but they increased it. And this basically is one of the things one should always be thinking about. And there's a tool that's available. Can we have the tool fly in, Tracy? So we have this checklist, and the checklist is both important for use before you start oxytocin, as well as use while you're running oxytocin, particularly for people who are just starting off their careers and are not that familiar with the standard approach to safe use of oxytocin. And this checklist goes through, what you should be looking for in terms of your electronic fetal monitoring interpretation. Is it a tracing that actually looks normal? Is it to some extent atypical but not abnormal? Or has it reached a point where it is now a complicated tracing which clearly demonstrates evidence of abnormality? Hand in hand with the safety checklist for electronic fetal monitoring, there's also the ability to look at what's happening to uterine contractions, which are an important and integral part of the use of oxytocin, and that's you shouldn't be overstimulating the patient's uterus. So there should be a limit to a number of contractions you see in a 10-minute window. You shouldn't have contractions that are lasting for more than 90 seconds at most. A lot of people don't use intrauterine pressure transducers, but we've also included, for those centers that do occasionally use an IUPC, the settings for what we're looking for in terms of resting tone and so on with an intrauterine pressure transducer. So the key issue or take-home message from this tracing is that you need to have these checklists in place that help you decide whether or not you continue with the oxytocin once you started it, and as well as whether you started altogether. And one can see from this tracing that not only did they continue with the tracing, with the oxytocin, but, and this of course is the worrying part of it, the oxytocin was increased. And you can see if one flips back to the first slide, can we go back to the first fetal tracing slide, Tracy? Yeah, it already was showing, let's euphemistically say it was showing less than a reassuring pattern. Next slide, please. And this continued, sorry, and this continued, and let's go to the final slide, please, Tracy. Till eventually this fetus was exhausted, to put it mildly, both exhausted in terms of its cerebral oxygenation and its ability to respond appropriately from a fetal heart rate point of view. But the key issue really for everybody, please, is to bear in mind that we have these tools that are an adjunct to the oxytocin protocol and should be conscientiously used and checked, particularly when you're training staff, but also for senior staff who sometimes are not sure what should be happening. I'm going to stop there and let Lauren go on with the second case presentation.
Thank you, Dr. Seaward. So for our second case study, we just want to acknowledge that it is quite a complex case study. There are a number of factors that came into play, and we are going to touch base on several of them, but we don't want to minimize how complex this situation would have been. So we'll start off with a review of what the kind of background to the case was. So we had a pregnant person who presented in spontaneous labor at term. This person had an unremarkable medical history and pregnancy. Her labor was augmented by IV oxytocin for prolonged labor and maternal exhaustion. During the second stage of labor, there were periodic atypical and abnormal EFM patterns that were observed by the primary nurse providing the care. This nurse did call the MRP to report the findings, and the MRP presented and reviewed the tracings and disagreed with the nurse's assessments, documenting that the fetal heart surveillance or fetal health surveillance findings were within normal limits. The nurse then went to the unit's charge nurse due to concerns with the fetal heart rate tracing as well as the orders. The charge nurse also disagreed with the nurse, and as a result, the nurse did not escalate the matter any further. Unfortunately, within this team, there was also a perception that feedback and escalation of care concerns was not welcomed, and that there was longstanding team hostility, instability, and unprofessional behaviors that impacted effective communication and safe care. Ultimately, the outcome was a stat cesarean section. Neonatal resuscitation was required, and sadly, the infant was diagnosed with moderate brain damage. Next slide, please. So I do want to preface this with, this is not a tracing from the case, but I did want to add that ambiguity within fetal health surveillance is very common. It's well known and it's a well-documented issue. The SOGC's 2020 Intrapartum Care Guideline recommends that all intrapartum healthcare providers obtain initial and ongoing fetal health, interprofessional team training in fetal health surveillance. In Canada, the fetal health surveillance education programs that are promoted for intrapartum teams all include mandatory components on team training, communication, and escalation of concerns when the response received by the healthcare provider who's expressing concern is not deemed to be sufficient by the person who is expressing the concern. The complexity associated with this case study is that the nurse providing the care identified both atypical and abnormal fetal heart rate patterns, escalated the concerns appropriately to an MRP who then disagreed. And as mentioned, when this happened, this nurse did go to their charge nurse. And unfortunately, the charge nurse also disagreed with the findings. The result of this, unfortunately, was the continued administration of oxytocin on an atypical and abnormal fetal heart rate. Again, with the limited information that we're presenting, we don't know for certain, but we could probably surmise that the 2 additional healthcare providers who were consulted were likely more experienced and had dismissed this person's assessments. And that either had the potential to dissolve this person's confidence in their knowledge and likely put them in a situation where they were no longer comfortable to continue to escalate their concerns. The other thing that it could have been related to, as outlined by the case study, is the environment that this case was occurring within. There could have been the potential from a professional perspective on what seeking out additional information would look like or mean for that person in returning to work on a later date. Next slide. So when we look at the key issues as they relate to the toolkit, we have several different issues that are brought forward that may have mitigated some of the risk that occurred here. We can see clearly that despite the complexity of the case, there were opportunities to implement tools within the toolkit. And the first recommendation that we would like to bring forward is recommendation number 3, which is the indications for induction and augmentation. So while the labor was documented as being prolonged, which would be an appropriate indication for augmentation in conjunction with additional assessment information, the clinicians also cited exhaustion as part of the indication. Exhaustion in and of itself is problematic if a case goes to trial because it is the feeling experienced by the person in labor. As a healthcare provider, this type of subjective data cannot be substantiated in court beyond the typical patient statement and healthcare team corroborating. But therein lies the issue, because if a person's baby is born with brain damage, the exhaustion statement without objective evidence can easily be turned back around. The second key issue is failure to act on an abnormal tracing. Acting on an atypical or abnormal fetal heart rate requires the clinical team to know what they're acting on and to act on it appropriately. So that's relating to recommendation number 4 of professional skills training in fetal health surveillance. When we look at recommendation 4 further, it states that oxytocin is prescribed and administered by a trained healthcare professional educated in its use, including the effects of and risks of drug administration. Specifically, this includes fetal health surveillance training, as oxytocin administration requires close and regular monitoring of the fetal heart rate and uterine activity. This training not only supports healthcare providers in recognizing atypical and abnormal tracings or abnormal uterine activity, apologies, but it can support healthcare providers in building confidence to voice their concerns. The nurse in this case did the right thing by recognizing the atypical and abnormal tracings and communicating it to the MRP and charge nurse. Unfortunately, though, as previously mentioned, the team dynamics impeded escalation of this issue further. So this leads us into the third key issue, which is failure to escalate and fully resolve care concerns, including non-compliance with local escalation protocols. So we want to focus on where recommendations and tools can support the mitigation of these concerns when they arise. So recommendation 2 within the toolkit, which is interprofessional team communication, states that members of the healthcare team must maintain communication that is clear, direct, and respectful. HIROC and the CMPA identify poor communication as a leading cause of oxytocin mismanagement, and the reviews indicate that failure to challenge questionable orders and or escalate concerns frequently result in adverse outcomes. So going back to our case, while the nurse attempted to escalate concerns twice within the case, there are long-standing and documented team dynamics and system issues that need mitigation. So now I want to bring your attention to a tool within the Implementation Toolkit titled the Decision Tree Disagreeing with the Plan of Care. So this is the second half of the decision tree. So when Mark presented the beginning of it, he showed the top half, and I want to really focus on the bottom half. And that is because the top half details exactly what the nurse in this case study did. And the bottom half helps to guide that nurse or that care provider in moving through a situation where the response is not what you would expect. So the tool details the need for hospital policies regarding the process to follow when there is a disagreement in the plan of care. And as emphasized in recommendation 2, there has to be an environment where all members can openly discuss the appropriateness of an oxytocin order, how it is being titrated throughout labor, and its effect on the fetal heart rate and uterine activity without hesitation or concern of instigating a conflict between the prescriber and the administering healthcare professional. In terms of the case study, this center would need to focus on addressing these environmental issues and creating a foundation to support this open communication and the development of safety and trust within their team. Next slide. When we look at additional key issues, of course, there is the major issue of failure to turn off the IV oxytocin and reassess the maternal and fetal status in the presence of concerns. So complementary to the additional key issues we've brought forward, this case is a classic case where there was a failure to turn off the IV oxytocin. This relates to recommendation number 10 within the document, which is stopping and restarting oxytocin administration. The toolkit states that healthcare providers are to be aware of when to stop, reduce, and safely restart oxytocin administration. Again, due to the complexity of this clinical case, we do not know why the oxytocin was not stopped. But one of the key common claims when discussing the mismanagement of IV oxytocin, as reported in the joint HIROC and CMP report, is failing to reduce or discontinue the infusion rate in the presence of maternal or fetal complications. Nurses and midwives, when administering oxytocin and monitoring patients undergoing IV oxytocin induction or augmentation, should be supported and expected to stop or reduce oxytocin infusion in the presence of complications and to notify the primary care provider as per the order set. So obviously for registered midwives, that may be slightly different than for a nurse. To support the implementation of the recommendation, we'll once again show you the in-use checklist because it can be an invaluable tool in integration if you can integrate it into your practice. So the in-use oxytocin safety checklist. So the full tool can be seen on the left-hand side. And again, we focused in on the continuous EFM assessment and uterine activity for you. So we want to focus on that. So as you can see, it provides indications of when oxytocin needs to be decreased or stopped. While the top of the checklist indicates that it should be completed every 30 minutes, give or take 5 minutes, the expectation is not for this tool to become an added piece of documentation to workflow. It's meant to guide clinical assessment and easily provide indications for when oxytocin needs to be decreased or stopped. So PCMCH would suggest having this checklist printed and in the patient's chart or potentially posted by the EFM while oxytocin is in use. We would encourage your team to consider how integration of this checklist into your documentation can be evident, especially in cases where oxytocin is being decreased or stopped. So an example might be upon identification of an atypical fetal heart rate associated with tachysystole, the person who has identified the concern and decreased or turned the oxytocin off would write an accompanying progress note indicating that at the time of the assessment, the oxytocin in-use safety checklist supported the clinical decision to turn the oxytocin off or to decrease it based on the identification of the various features of the fetal heart rate or uterine activity. So as you can see, the tools available to support the safe administration of oxytocin by highlighting key clinical information will help to decrease the risk of poor outcomes. As healthcare providers who are responsible for the administration of this very complex and dangerous drug, it is our responsibility to be conscious and operate with the knowledge of the damage this important high-risk medication can cause. So a slow and steady approach using tools from the safety safe administration of oxytocin in labor toolkit can always be of use and can help to enhance teamwork and communication. Thank you, Brittany.
Great. Thank you so much, Lauren and Gareth, for walking us through those case studies. There's been an influx of questions and some comments that have been coming in. But Lauren, I think I'll start with one for you as it's related to the second case study. We have a question asking, is the RN able to discuss her concerns with the client? Where does client participation come into play here when there is a disagreement in the plan? And anybody else is welcome to dive into that one after.
Yeah, I would actually really welcome additional panelists to speak to this, and it's a fabulous question. I think that given the nature of the need for there to be patient consent, there needs to be patient consideration included in the decision to increase oxytocin if there are concerns present. And ultimately, a patient, I would think, has the absolute right to say, I no longer want this medication administered, or I do not agree with continuing to increase it. It's a very complex decision, though. It's not something that we can say, you know, black and white, we're going to turn off this oxytocin, everything is going to be okay, because there are so many influencing factors that are contributing to the clinical information that is driving the decision-making process. But absolutely, the patient has the right to be a very important part of this conversation, and I think ultimately the decision maker in stopping. But I see Joanna's turned her camera on, so I'm going to let her go.
Great.
Oh, that's great. No, I think you brought up a really good point, because I think I was talking about the concept of informed consent or choice as it relates to IV oxytocin, and the client does play a significant role. I think what, just in terms of what we're seeing in Canada, is that, you know, if you're a nurse, midwife, or physician, and you see, you know, bad tracing, and you see some concerns, the expectation is that you're going to do something about it, and you can't just sit on it anymore. I don't think you ever could, but I think it's basically case law says that, you know, you have an obligation to that person to escalate that care concerns. Yes, and I think, you know, having, you know, that client awareness of what's happening, but I think it also means you have to go further. If you know something's wrong. Often what we see in these cases is that, you know, the bedside practitioner will say something like, I knew something was wrong, but, you know, I deferred back to the MRP, but I just kind of sat on it. I knew it was wrong. You can't, I think that basically what we're trying to say is that you have to do something about it, go a bit further. And I think, as you said, that's the use of some of these tools, but I think the client does play a significant role.
Thank you both. Gareth or Mark, did either of you want to weigh in?
All I was going to say, absolutely, the woman and her partner should be involved in any concerns about the use of anything that we're utilizing in labor. It just, it would be very strange to manage a case where there is concerns by somebody that the tracing is not consistent with safe use of oxytocin, not to tell the woman or her or her partner that there are some concerns. I think the key take-home message from that is it will force, because no potential MRP is going to force the issue of overriding the bedside nurse in the interpretation of the fetal tracing if both the nurse at the bedside and the woman and her partner are turning around to the MRP and saying, is there a problem with this tracing? I think it forces yet another check and balance in reassuring us that we're using oxytocin correctly.
Thank you, Gareth. And also, I did put in the chat there, we mentioned it a little bit earlier when Mark was presenting, but the ISMP Canada 5 questions to ask document I put the link there, but this is a patient handout providing education, providing information, getting the appropriate tailored information in the hands and in the minds of who it needs to be, the patients and their partners, their families, their support persons. So this really, the intent of it is to increase the role of the patient as a partner in intravenous oxytocin safety. And that's not a one-time thing, that's a continuous thing. So I encourage you to take a look at that, the link there, but it is also in our implementation toolkit as well. So I have another question that came in, and it's about birth trauma. So I thought maybe some of you could weigh in, of our panelists here, and speak to this. So just about perception and perspective. So when we're referring to birth trauma in some of these cases and examples, are we referring to perineal trauma and repair? Or are we referring to the mother's or the birthing person's perception and experience of their birth as birth trauma? So this really is about the lens in which we're viewing things. So for today's session, this individual wanted to know what type of birth trauma are we referring to?
I can just jump in. I think I used the word birth trauma in one of the reports, and it's meant to include both harm to the fetus, neonate, and or mom. We just at the time used the word birth trauma. So for us, it incorporates all. So it's not just limited to that neonate or fetus.
Thanks, Joanna. Anybody else want to weigh in on that one? I think you covered it. Not seeing any unmutes. Great. So another question that we received is, what do you do when the healthcare provider says that the patient will never deliver if she doesn't have contractions? So without us getting into too much of the minutia of individual clinical care, maybe one of our speakers could answer that.
I guess the issue is what that means in terms of no contractions whatsoever, or is it referring to contractions that are deemed clinically inadequate? I need more explanation of what that actually means. What did that person mean by that? No contractions at all, or just contractions that clinically seem to be inadequate? So if there are no contractions at all, then at some stage we have to have this woman get into labor, whether one waits for spontaneous onset of contractions or whether one starts with, for example, spontaneous rupture of membranes but no contractions and initiates an oxytocin induction of labor. That is different from contractions that are judged to be clinically inadequate. And therein one has to rely on other components of the clinical scenario. So for example, if a woman is progressing in terms of dilatation and there's clearly appropriate dilatation at the acceptable intervals that you'd expect, then the fact that people feel that clinically the contractions are inadequate is of no value, because, well, not true, because the woman is progressing. If clinically the woman is not progressing in terms of dilatation and the patient is felt to be not having appropriate uterine activity, that's when one starts thinking about use of oxytocin with or without use of an intrauterine pressure transducer. Most of the time, appropriate clinical bedside evaluation of the woman helps you decide whether the contractions are adequate or not, both in terms of their frequency and intensity. So you need to be a bit more clear about what you mean by she won't deliver if she doesn't have contractions.
Yeah, they commented in the chat to say clinically inadequate, but I think you covered a whole range of possibilities there. And again, it's very hard without all of the clinical context to really give a straightforward answer, but I really appreciate your reflections on that, Gareth. Another question that's come in is, can you speak to considerations in rural settings where transfer to a higher level facility or access to consultants may be delayed or limited? And I recognize that this is a big question, but if any of you have some reflections on that, that would be helpful.
Walker, are you going to comment?
So I guess just to differentiate between rural and remote, maybe, because rural, could be a hospital with 50 deliveries. It could be with 250. We do appreciate it's going to be a challenge for the practitioners in, rural settings with the recommendations, and these are best practices, but at the same time, you have to adopt what you can in those centers.
Thanks, Mark. Did anybody else want to weigh in on that one? No. Okay.
So I was going to weigh in.
Go ahead.
Brittany, I think the key issue is, irrespective of whether you are using oxytocin in the setting of a rural community or a small level 1 hospital or whatever, the guidelines that we've put in place are such that anybody using oxytocin should be able to use these guidelines to help them with the appropriate use of oxytocin. And I guess the flip side of that is, if you are uncomfortable interpreting the guidelines or uncomfortable interpreting fetal tracings and so on, you probably shouldn't be using oxytocin. And it doesn't matter whether it's a small community-based hospital or a big level 2. If you don't really feel comfortable with the use of oxytocin, don't use it. It's as simple or as complicated as that. There is no excuse for using a drug just because it's available if you don't really know how to use it. And that is the whole point of putting together this package, so that people can upgrade their skills and assess themselves as to whether or not they're actually on par with what is currently the accepted standard of care in 2022 for women who receive oxytocin in labor.
Thanks, Gareth. And that's exactly right. These are best practice recommendations. So we truly recognize that they need to be tailored to the individual unit and organization, and even the types of patients that you care for. So it's very difficult in a standardized way across the province to have a one-size-fits-all, and we don't intend for that at all. So as always, we're here at PCMCH. I'll put the email in the chat, but we are open to having conversations about what these tools look like and what your clinical context is. There are a number of questions coming in, but we are out of time. So we will try and get to those in a written document. Some of them are quite specific in terms of clinical situations. So I encourage you to take a look at the documents, and you may be able to actually find some of your answers in those. So thank you so much for attending today. There is so much to unpack, and we just kind of skimmed the surface of this topic and could go on and lots more case studies when it comes to the safe administration of oxytocin. So in looking at the audience, I was beyond pleased to see the range of healthcare providers that we had present today. I saw midwives, nurses, professional practice leaders, family physicians, educators, managers, and that was just a quick skim. And we had people from across Ontario, but also across Canada. So I think we need to keep this on the forefront as a really important topic to address. And to close out, your feedback is really important to us. Please complete the survey that will pop in your browser after this webinar, and that will give us an opportunity to get in touch with you, and you can provide some feedback on the webinar, but the broader documents. And looking ahead, we will be evaluating the implementation of the best practice recommendations and how they're implemented in units, organizations across the province in the coming year. So we really are eager to learn about your local experiences. So that concludes our webinar. Please note the recording will be available later in this week on the PCMCH website. And I'd like to extend my deepest gratitude to our presenters today. They were all amazingly flexible in their time and energy and spending their lunchtime and beyond with us today. So a big round of applause for Joanna, Mark, Gareth, and Lauren. We really appreciate it. I hope everyone in the audience gained something from today's presentation. And thank you so much for joining us. Have a great rest of your day.
Bye, everyone.